receive, will to welcome, pardon, cleanse, relieve, because thy promise I believe, O Lamb of God, I come, I come, because thy promise I believe, O Lamb of God, I come, I come. Thy promise I believe, O Lamb of God, I come. I be not dismayed, whatever betide, God will take care of you. Beneath his wings of love abide, God will take care of you.
Good evening, everyone, and welcome to our Tuesday evening Let's Talk Health program. You could have chosen to be anywhere this evening, but you chose to be with us here. So we are very grateful for that and thankful to God. You know, week after week, we have been coming to learn about various types of diseases, how they affect our bodies, and what steps we should take in case we get sick. There are so many people that are sick and suffering out there, and God has called us to take up the mantle and to bring 1, hope to the hopeless, 2, healing to the sick, and 3, salvation to those that are in darkness. I pray by God's grace that we will be channels of light in a dark world full of darkness. And we will share these life-changing experiences and information with others that they too can experience both physical healing and spiritual growth and restoration. So welcome one and welcome all. Please bow with me as I open up in prayer. Eternal God and Father, we just want to give you praise and thanks for this opportunity where we could come again, oh Father, on another Tuesday evening. Let's talk health to discuss, oh Father. Lord, you said in your holy word that your people perish for lack of knowledge. So even now, we are so thankful, oh Father, that you are using this platform, oh Father, to bring those messages out to the people so that we do not remain in ignorance. Lord, I pray that you would bless us. I pray you would bless the presenter. And I pray that you would open our understanding, oh Father, that the word which is spoken to us this evening, that we would digest, oh Father, and that we would not keep it to ourselves, oh Father, but that we would spread it, oh Father, like leaves of autumn. Thank you, O Lord, and we give you all the glory and honor. In Jesus' most holy and precious name, I pray and ask with thanksgiving. Amen and amen. Our speaker for this evening is Dr. Gerard M. Antoine. He was born in Trinidad and Tobago and attended Holy Cross College prior to immigrating to the United States of America at the age of 14. He served 31 years in the United States Army and retired in September 2016 as a lieutenant colonel prior to returning to Trinidad and Tobago in October of 2016. Dr. Antoine graduated with a Bachelor of Science degree in biology from Virginia Commonwealth University, Richmond, Virginia. He completed his medical doctorate degree and earned a Master's of Business Administration from the University of Tennessee, Knoxville, Tennessee. Dr. Antoine served as a combat medic and certified respiratory therapist during the First Gulf War. He served as a battalion surgeon for the 10th Mountain Infantry Division in Iraq. He also served as a squadron surgeon for the 3rd Infantry Division in Afghanistan. Dr. Antoine is the only American residency-trained physical medicine and rehabilitation physician in Trinidad and Tobago. Dr. Antoine serves as a senior consultant physician and oversees the rehabilitation department at the North Central Region Health Authority, Mount Hope in Trinidad and Tobago. Dr. Antoine is the medical director of the inpatient rehabilitation facility at the Community Hospital of Seventh-day Adventists in Trinidad and Tobago. But before he speaks to us, we will first listen to our theme song, and after the theme song, we will hear of Dr. Antoine. Our theme song. Amen. Disease, disease, disease. What is disease? Disease is an effort of nature to free the system from conditions that result from a violation of the laws of health. In case of sickness, there are 4 steps that should be taken. Step number 1, the cause should be ascertained. Step number 2, unhealthful conditions should be changed. Step number 3, wrong habits should be corrected. And step number 4, nature is to be assisted in her effort to expel impurities and to reestablish right conditions in the system. So the next voice you will be hearing is that of Dr. Antoine. Over to you, Doc. Yes, Dr. Gerard M. Antoine, it's your turn. Over to you. Doc, are you here? Are you hearing me?
Hello?
Yes, yes, now we could hear
Hello?
you now.
Hello?
Yes, we could hear you.
Hello? 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 Anyone out there? Who? Look at all these people.
Yes, can you hear me, Doc? We are hearing you. Doc, are you there? Your mic is muted, so we can't hear you. So you could unmute your mic so we could hear you. But as for now, we can't hear anything that you're saying because your mic is muted. Yes, if you can hear me, Doc, your mic is muted, so we can't hear anything you're saying. So you could go ahead and unmute your mic so we could hear you.
Dr. Antoine, we're not hearing you. In case you're speaking, we're not hearing you because you are muted. So please unmute yourself and so that we can hear you. Until he speaks, we'll just listen to the theme song again. Dr. Antoine, are you hearing us?
Hello?
Can you hear us? You are muted.
Hello?
We're not hearing you. So we can see your mouth moving, but we're not hearing what you're saying.
Hello?
Your mouth is moving, but we're not hearing you. Maybe your volume should be turned up.
Is anyone out there?
You're speaking, but we're not hearing. We can see your mouth moving.
We are hearing him, a matter of fact. I am hearing him, but it seems that he can't hear you because I'm hearing him saying hello.
Okay, proceed. They're hearing you. They're hearing you. Proceed.
I don't know why no one's hearing me.
Yes, we are out here.
Can anyone hear me?
Yes, we're hearing you now. Loud and clear. Please proceed. We are hearing you. Can you hear me? Dr. Antoine, can you hear me? Dr. Antoine, can you hear me?
Wow. Hello?
Yes, can you hear me, Dr. Antoine? Can you hear me?
Oh, but I can't hear anyone. Oh, hold on. Hello?
Yes, can you hear me?
I can hear you now.
Perfect. And we are hearing you, so go right ahead.
Okay, I thought we were supposed to get started at 8.
Oh, no, not 8 o'clock, 7:30 Canadian time and 6:30 Jamaican time.
And so 7:30 is
Yes, 7:30 EDT 7:30. So we are on time and we started on time as well.
so I am on time. I'm not late.
No, you're not late. So it's over to you now. We've been waiting for you to speak. Thank
All right,
you.
excellent. So let's do this. Right. Hi. Do I introduce myself or you're going to introduce me or?
You were already introduced.
Okay, hold on.
You were already introduced.
Allow me to share my screen.
Absolutely. Go ahead. You can. You've got your co-host. You can share your screen. So go ahead. And you were already introduced. So go right ahead.
Okay, let's see. Share screen. All right, let's see. Share screen. So I am not able to share my screen here for some reason.
You went to the bottom and you hit your screen.
Here we go.
So hit your screen at the bottom and you should be able to share your screen.
All right. That's doing this. Are you seeing the screen?
We're seeing you. Hit your screen and then select the screen you want to share.
I'm doing that. And for some reason, hold on.
Okay.
Hold on, I'm having some challenges here.
That's fine, no problem.
Let me sign out and sign back in because I'm really, this shouldn't be that difficult. And then I've done this a billion times.
I understand. It happens, technology, right? So we understand.
I don't know why it's not allowing me to do this.
Okay, let me do this. Let me make you host, see if that will make a difference.
Let's do this. Let me sign out and I'll
Sure,
come back in and
no problem at all.
and let's see what happens there, right? Because this is
Sure.
really irritating me.
No problem at all. So you can do that and come right back in and we'll be looking out for you.
All right, here we go. Hold on. All right.
Okay,
Wait. Well, let's see. Share screen. It's not doing it. It's not allowing me to share my screen. Jesus. So there's something.
try again one more time and let's see. So
So
go,
I'm doing the multiple participants can share screen simultaneously.
okay, try one more time, just share screen and let's see.
Because you have to allow me to share my screen, and I think
You can. Once you're co-host, you're able to share your screen at all times. So you do have the privilege to share your screen. I'm going to make you host and see if that makes a difference.
all right, let's do that.
Okay. Because once you're co-host, you can share screen. So I'm just going to hand over to you. Then you can make me back co-host. So let's try your screen now. Yeah, it's still not happening. Still not seeing your screen.
Yeah, it's not working here for my shared screen. So let me do this. Let me sign out and
Absolutely.
I'll sign back in.
Do that for sure. You can just make me host before you go back out.
Okay, make you host.
Yes, so it's Angela. And we welcome you once again to Let's Talk Health.
So how do I'm not seeing your, because remember I'm using a Mac and my Mac is not allowing me to do that. One participant. So make yourself share screen. Yeah, it's not allowing me to do that.
Okay, you can sign out and come back in.
So let me end.
Brother Gerard, you're now host. Please make me back co-host or yes, you can make me back co-host. Thank you. Okay. And while we're waiting for Dr. Antoine to join us back, let me say welcome to everyone. We see we have some new faces on tonight. Wherever you're joining us from, welcome, welcome, welcome. Those from Jamaica, we welcome you. Those from St. Martin, we welcome you. Trinidad and Tobago, welcome. St. Lucia, Barbados, we welcome you. Guyana, all over the Caribbean, welcome. From Canada, welcome. From the US, welcome. From Guadeloupe, yes, from Guadeloupe, welcome. From as far as South Africa, welcome. From the UK, welcome. And wherever you're joining us from, a hearty welcome to Let's Talk Health. Remember, we do this every Tuesday night. No need to wait for a flyer. Dominica, yes, welcome. No need to wait for an invitation. No need to wait for a flyer. We welcome you at all times. Those over there on YouTube, welcome to you also. Always a pleasure to have you on. And we know that you're faithfully waiting for us on a Tuesday night over there on YouTube. So welcome also. As you know, the topic tonight, we're looking at stroke, and very soon the doctor will be on because that's his specialty. It's not mine, so I don't speak on such topics. And that's why you're here to hear from a professional who knows exactly what he's saying. So we're happy to have you. And let me just check if he's back on. If he's not back on, I'll just play our theme song again until he comes on. Or if you're joining us for the first, okay, so he's back on, and I'll make you co-host again, and then you could try to share your screen. So you can now try to share again, Doctor. And the numbers are climbing and more people are coming in. You're muted. Please unmute yourself and speak.
Can you hear me now?
Yes, we're hearing you now.
It's not allowing me to, for some reason, it's not allowing me to share my screen at all, right? I don't know why that is.
Yeah, I'm not sure why, but I'll make you host again to see if that will make a difference. But once you're co-host, you have share screen privilege. Let's see, I'm gonna make you host and hopefully that makes a difference, but I think it's your computer, something is happening on your end.
Yeah.
Okay, but let's try again. But we understand technology is like that. It works sometimes and another time it does not behave itself well.
Yes. So let me do this. Let me send the it's not allowing me to do it at all, at period. So it's for some reason. So let me send you the PowerPoint slide and see if you can open it. Okay?
Yes, okay.
All right.
Okay, so let me put the email address in the chat.
Okay.
Email address in the chat.
Got it. Leap to Health.
ja@gmail.com.
All right, it's off. You should have it by now. Hello? Ugh. Are you there? Hello? Jeez.
Okay, thank you. Now I can speak. So yes, did you send it?
I sent it.
Perfect. Let me just open up. Because I made you host, I wasn't able to unmute myself. So can you please make me back co-host so I'm able to also help with monitoring? And thank you.
And I do that by,
Just look for my name and you'll see a drop-down arrow and you'll see the options to make me co-host. And I do have your PowerPoint and I'm opening it up now so that we can share it on the screen.
Philomena Charles, right?
No, it's Angela.
I'm sorry.
Yes.
Angela.
Yes. So I do have it. So I'm just going to open it up now and you'll be able to see it.
Angela, where are you?
Should be at the top of the list.
Angela, here we go. Got it.
Yes. So I'm going to share the screen for you.
We have 60 people on tonight. Hi, guys.
Mm-hmm.
Why Angela is getting the screen set up, right?
Yes, I'm getting it set up.
Does anyone believe in angels?
Well, I am one, so yes, I do believe.
I believe in angels. So of all the other things in life, I believe in angels. I have a lot of angels. I have, while Angela's getting that set up, are you able to open the
Yes,
PowerPoint?
I opened it. And now I'm about to share the screen right now as we speak. And yes, I believe in angels because I'm one of those angels.
You are. So great, excellent. So here's my angel story because we're having, can you do the full screen? And like from the beginning, slideshow.
Yes, I'm doing that.
Cool, thanks. So my angel story, and I'm sure everyone has an angel story. So my name is Gerard Antoine. I like Gerard Antoine, but in Trinidad, everyone calls me Gerard Antoine, but that's my name I was born with, Gerard Antoine. So I guess I'm Gerard Antoine for the night. So I am the medical director of the Stroke and Diabetes Center And I know we've kept you guys a little bit over time, but I supposed to start it, but my angel story is I was about to do a presentation and had a meeting with the CEO of Community Hospital about 5 years ago when I first came home, and I have had a massive blowout. My spare tire, my tire blew out on the road in the rain, and I had on a suit and a tie and a white shirt. I got out the car to fix my tire, and I put the jack in the wrong place, and the car started slipping in the rain. And this elderly man walked by. He looked almost homeless, and he said, "Let me help you." And I said, "I don't need any help." You look in my head, he looked homeless. I'm about to get jacked. The guy changed the tire in about 5 minutes. After he insisted that he help me, he said, "Let me help you, let me help you." And I drove off, went to my meeting. I gave him all the US dollars that was in my pocket. I went to the meeting, and at that time, the CEO said, "Yeah, when I can't meet with you today because I have something else to do." Incredible. That guy saved the day in my car from falling on me in the middle of the rain in Trinidad and Tobago. Nonetheless, that's my angel story. Again, I was asked to present a topic on stroke, and I am truly honored and grateful and feel blessed to share this opportunity to present this program. Next slide, please. Since I can't change the slide, you'll have to help me. A few disclosures. I'm the medical director of the Stroke and Diabetes Center, Trinidad and Tobago. I'm also the medical director of the inpatient rehabilitation facility at Community Hospital Seventh-day Adventist in Trinidad and Tobago. I'm a consultant physician for one of the North Central Regional Health Authorities in Trinidad and Tobago. I'm also a retired colonel, a lieutenant colonel in the United States Army. I have 2 combat tours in Iraq and Afghanistan, and I did Desert Storm too, but I guess that wasn't much of anything. All right, next slide, please. All right, I'm just going to tell you guys about who I am. What am I doing out here in the Caribbean? Why do my specialty get involved? What is strokes and what is post-stroke stroke care, and the benefits of stroke care and inpatient rehabilitation. All right, next slide, please. Right, I am a physiatrist. I am the only physiatrist in Trinidad and Tobago. If you have a question, please raise your hand. Please feel free to make this as interactive as possible, okay? So how much time do I have? So I can run through the slides quickly, or I can slow it down.
You have normally about an hour for presentation and Q&A.
Okay, so I have time. So when should I end? Like around what, 9 o'clock?
We end 9 o'clock EDT time, and yes, 8 o'clock our time. So yes, okay. Jamaican time is 8 o'clock. But okay, if you go over a little bit, that's fine. But we want to get in all the questions. So you can finish the presentation and then we can ask the questions. We can take questions from people. Excellent. So I am a physiatrist. I know in Jamaica, there's one physiatrist. In Tobago, in Barbados, there are about 3 of them. In Trinidad and Tobago, I'm the only one. So my role as a physiatrist for specifically for stroke patients, no, go back, please. For physiatrists, my role in the treatment of strokes is primarily to decrease stroke mortality, right? Decrease the recurrence of strokes, decrease disability, and allow the patient to become as functional as possible after their post-stroke care. All right, next slide, please. So there's a specific definition of strokes, right? The World Health Organization defines stroke as a clinical syndrome of rapid onset of focal cerebral deficits lasting more than 24 hours, leading to death with no apparent cause other than vascular. What does that mean? Stroke, because stroke has a specific definition, most times people get mixed up with a stroke with like a Bell's palsy, when you have a facial nerve paralysis from some form of viral illness. Stroke presents with facial weakness
arm weakness, speech impairment, leg weakness, and sometimes a lot of facial drooping and tongue, the tongue protruding on the opposite side of the stroke, right? That's what the definition of stroke is. So a TIA is very similar to a stroke. However, the symptoms of stroke will last more than 24 hours. However, a TIA, which is a transient ischemic attack, with the same types of symptoms, with the facial weakness, the arm weakness, the leg weakness, right? And the speech impairments, right? But however, the symptoms last less than 24 hours. Next slide, please. Right? Some risk factors for strokes, and most people know what they are, right? It's high blood pressure, right? Which increases your risk of stroke significantly. Is diabetes, which also increases your risk of stroke by 2%, by 2 times, I'm sorry, twice than the individual who does not have diabetes. High cholesterol. I have seen, however, there's been research that shows that truly high cholesterol may not have anything to do with strokes. And you know, medicine is changing rapidly, almost daily. So, for example, out in Trinidad and Tobago, I have practiced family medicine for a couple of years, and as a physical medicine rehab physician for many years, probably about 20 years now. Usually in the States, we start treating patients with high cholesterol with a number of 180 or higher in the States, right? In Trinidad, the number here is about 200. We usually start treating patients who have total cholesterol higher than 200 with medications, usually a statin. And usually statins are like simvastatin, Crestor, right? Rovastatin, right? Those medications cause a lot of problems with muscle aches and pains. So I usually don't, I'm very conservative, right? I'm very liberal. So meaning if a patient has a cholesterol of 210 or higher, I usually don't start him off on cholesterol. I allow him to do some weight loss. I allow him to do some other things before I start medications, right? Some diet changes and exercise. Heart disease also increases your risk of stroke. Atrial fibrillation. So what does atrial fibrillation mean? Normally, every one heart beats like a rhythmic function. It beats boom, 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 boom. And I always tell my patients, you get so many heartbeats in a lifetime, you know, about 60 to 80 a minute, multiply by 24 hours, multiply by how many hours in a day, multiply by how many years. So if your heart increases in the number of beats and it goes from 60 to 80 a minute to 140 a minute, boom, 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 which obviously means you're not going to be here for long, right? It decreases your lifespan, right? So atrial fibrillation is when your heart beats, the atrium beats rapidly. Instead of going boom, 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 it goes brrr, brrr. So that allows you, it allows the heart to pool, and it can cause blood clots in some clot or an embolus in your heart, and can cause problems with strokes. If you've had a previous stroke, it increases your risk of another stroke by almost 25%, right? And I always tell my patients who've had strokes, especially the ones who are doing well, if you've had a stroke in the past, stroke knows your name, it knows your house number, it knows your children, it knows it's coming back. So when it comes back, it is important, it's imperative that you make sure the door is closed, you take your medication, your blood pressure is down, your diabetes is under control. So it may turn the doorknob, it may try to get in, but it won't get in because you are well prepared for its return, right? Smoking, these are things that we can control. Previous mini strokes, alcohol intake, obesity, and lack of exercise. These all increases your risk of strokes. Okay, next slide, please. So there's an acronym for strokes and the symptoms of strokes. And we usually, it's usually say it's be fast, or FAST is a usual acronym we use. So the symptoms, the clinical features of stroke is number one, right? Hemiparesis, this means weakness on one side. And you have the facial drooping, which is the F, the arm weakness on the same side, right? Right. Or you can have weakness or complete inability to use that arm, which is paraparesis. Dysphagia, which is the inability to swallow, which means you start drooling with the drooping of the face, you start drooling. And most times the family may notice it before the patient may notice it. For example, you may see a family member was like, hey, John, your face is drooping, and the patient may not even know it. Or you're drooling on yourself. Ataxia means abnormal balance, right? And speech is aphasia, inability to speak is aphasia, or dysarthria is the difficulty speaking, that's speech, right? Or you may also have blindness in one eye or decreased vision in one eye, or double vision, or sometimes you can even have loss of consciousness. So that's the FAST, facial weakness, arm weakness. FAS is speech impairment, difficulty speaking or inability to speak at all. Then it's time to call the ambulance. Okay, next slide, please. Okay, so there are different types of strokes, obviously. And I'm going to do this like I do it in Trinidad. It's not the way I do it in the States, but here's what, because I tell patients, it's like an ischemic stroke is the most common stroke. It's a blockage stroke. It's like water in the grass, and suddenly the hose gets blocked. And the longer the hose is blocked, the grass dies quickly. The grass being your brain, and the hose being the carotid arteries in your neck. So the goal, and the body normally heals itself. The goal, the blockage in the hose, the carotid arteries, can be cleared by the body itself. If it is not cleared, we have rapid loss of grass or the brain tissue, right? So there are different, 80% of most strokes are ischemic strokes, what we call blockage strokes. And it can either be a thrombus or embolic stroke, right? A thrombus is just a big blockage, a big clot in the blood vessels of the arteries that prevents the blood from getting to the brain. Or an embolus is where a piece of the clot breaks off and goes to a smaller blood vessel and blocks the blood flow to the brain. Nonetheless, ischemic strokes are the most common. Now, I go to Tobago every Wednesday for the last 4 years. Every Wednesday. If I show you the numbers for stroke patients in Tobago, it's so impressive. At the age of 40s on upward, to as low as in the mid 30s. We are having, and I keep all the data. We just need to publish it once the ethics committee signs off on it. It's so impressive how much strokes we are having in Tobago and compared to Trinidad. And there hasn't been any research, some scientific research done, and they'll usually extrapolate Trinidad's numbers to Tobago. But I am sure anecdotally, there's a significant difference. I don't know why. Well, I have assumptions of why that is, right? But it is significantly different based upon what I see, right? So that's ischemic strokes. Next slide, please. So the other type of strokes are hemorrhagic strokes. About 15% of most strokes are hemorrhagic strokes compared to ischemic strokes. So hemorrhagic strokes are a bleed, right? Where you have these little bulging tissue in the arteries and they rupture. That's called an aneurysm, right? And you have just definitive intracerebral bleeding, that one of the large blood vessels, because of high blood pressure, ruptures because of the high pressure, and it causes bleeding. Now, the challenge is most patients who have ischemic strokes survive. Most patients who have hemorrhagic strokes do not survive. And the numbers bear it out like almost evenly. About 75% of the patients who have ischemic strokes have a lot of disability, however, they survive. And about 75 to 80% of patients who have hemorrhagic strokes die. Right? Next slide, please. Right? And these numbers are just primarily for the Caribbean. You see the number of the diabetics in Trinidad and Tobago and across the Caribbean. I picked out a few Caribbean islands, right? The death rates due to the mortality rates due to diabetes in the Caribbean, which increases your risk of strokes by 2 times higher than if you did not have diabetes. Now look at the numbers as you see from Guyana, Trinidad and Tobago, Grenada, Jamaica, Barbados, compared to the United States, Canada, and UK, right? You look at the mortality rates of those, if you want to call them developed countries, and we are developing countries, right? How significant those numbers are. It's, in Trinidad, the numbers, I think it's almost 20% of our population are diabetic or pre-diabetic. I believe that's the correct number or close to it. Right? And these numbers are impressive. And this is from the World Health Organization and the World Bank database. Okay. Next slide, please. Now, and we talked about diabetes. For patients who are diabetics and they have a significant 2 times higher risk of having strokes, the key number to control is your A1C, right? Now, based upon my experience here in practicing medicine in Trinidad and Tobago for the last almost 6 years now, I would have patients who've had diabetes for 5 years, 10 years, and they haven't a clue what an A1C is. And how I usually explain what an A1C is, it's the average sugar over a 3-month period. And what it does, it gives you a better control. It gives you a better idea how well your diabetes is controlled. Now, taking a finger stick blood sugar it just tells you, it's a snapshot picture of where your blood sugar is at the moment. It's like taking a Polaroid picture of yourself, even if you're depressed, however, you're smiling. Just because you're smiling doesn't mean you're not depressed. It's a snapshot. So for every 1% increase in your A1C, the risk of a stroke or heart disease and death is increased by almost 10 to 30%. So you see the difference in patients who may have a A1C of 9 or 10 versus 5.6 or 7. It is a significant difference. That's why we work diligently to control the patient's A1C. And you can see here what normal A1C is. It should be below 5.7. But I give him in Trinidad, we give him a buy or bly, right? So usually I would tell patients, if they've been a diabetic for many years, I would say, as long as we get it below 7, we're good. The goal is 7 for me. Get your A1C down below 7, and I am a happy camper. I will not buff you up. All right, next slide, please. Hypertension. This is almost every patient I see who's had a stroke. Almost, not all, not 100%. Almost every patient I see with a stroke, especially in Tobago, have already been diagnosed with hypertension. And look at the mortality rate per 100,000, right, throughout the Caribbean. It is incredible. The numbers are incredible. And what I have seen in our country and throughout the Caribbean, and I've done this in Guyana, I've done some in Barbados, and I've also done some cases, seen patients in Grenada. our culture is such, we're not as trusting of medications, especially foreign medication, as they are, as my patients were in the United States. So trying to get someone in Tobago to take their hypertensive medications is a challenge in itself. So I get cashew leaf tea, dashing bush leaf tea, nutmeg is very common, especially when patients have strokes, right? I put a nutmeg under my tongue, and there is some truth to that, because nutmeg has some what we call vasodilation properties, where the blood vessels enlarge. So I looked that up because I have never heard this before until I got to Trinidad, came back home to practice. And so patients do use nutmeg a lot here, and there are some benefits to using nutmeg, by the way, right? So what is normal blood pressure, right? We say normal blood pressure in the States is 130/80, right? So elevated blood pressure is so here, and that's the definition of high blood pressure. Anything above 130/80 is considered high blood pressure, which is, we consider some 130 to 139 to 80 to 89 is stage 1 high blood pressure. And I'm a little liberal, so I usually don't start treating from like 140/90. I try not to treat, but stage 2 high blood pressure and stage 3, you definitely have to treat. Anything higher than 140/90, we need to start treating the patients for high blood pressure, right? And I'm usually, by the time we find a patient with high blood pressure, they've already had high blood pressure for many years. So too with diabetes. It's said that once you diagnose a patient with high blood pressure with diabetes, they've had diabetes for almost 5 years already, right? Next slide, please. So the challenge here is, okay, strokes can be prevented. We can prevent strokes. If you have high blood pressure, 80% of strokes can be prevented. If you have high blood pressure, take your medication, manage your weight, manage your cholesterol. Yes, I know cholesterol medication may have side effects. Yes, we know blood pressure medications have side effects. But the key here is to get your blood pressure down, either by weight control, aerobic exercise. And aerobic exercise isn't walking around. I'm a registered nurse. I am busy all the time. I work outdoors. Exercise have a definitive meaning, right? Exercise is usually defined by us, the rehab doctors, is increase your heart rate to 1.5 to 2 times its resting heart rate. And these days, these watches that may have a heart rate on it is pretty inexpensive, right? You can buy a Fitbit, you can buy those little cheap watches that have, so you can know what your resting heart rate. So if your resting heart rate is 75, trying to get your heart rate up to about 100 to 150, right? For a minimum of about 15 minutes is considered exercise. So if you're doing a lot of sweeping and housework, that is not exercise. Increasing your heart rate from 1.5 to 2 times its resting heart rate for about a minimum of about 15 minutes, right? So, and if you've had a stroke previously, right, your risk of having another stroke, as I said previously, is almost 25% higher of having a second stroke. That's why I tell patients, stroke knows your name, it knows your address, it's coming back, and you better make sure, right, that the door is closed. If you've had a stroke in the past, most doctors, most recommendations in England, now that I know what the English recommendation, sometimes it's somewhat different than the American recommendation, but I'm sure they're very similar. If you've had an ischemic stroke, the recommendation is that you should be on we call them antiplatelets. Patients call it blood thinner. It's an aspirin, right? If you've been on aspirin and you have another stroke, I call the aspirin the lock on the door to prevent stroke from coming in, right? If you've been on aspirin and you have another stroke or a TIA, a transient ischemic attack, you should be placed on a second antiplatelet, which is usually Plavix, right? So patients could be on aspirin and Plavix, 2 antiplatelets. If you have a hemorrhagic stroke, we usually do not put the patient on aspirin immediately or Plavix immediately, right? So, so that's the antiplatelet or blood thinners. Now, patients will tell you, well, I don't want to be on a blood thinner because it is make you bleed. Well, here's the risk. If you do not have a blood thinner or antiplatelet, either aspirin or Plavix, when stroke returns, which it will or may return, and it turns the handle on the door, they will get in pretty quickly or easily, and you will have another stroke. And each time you have a stroke, it will get worse, right? Next slide, please. Now look at the stroke mortality rate, right? The death rate throughout the Caribbean compared to the United States, right? It's significantly high, especially in Guyana and throughout the Caribbean. And you look at the US, Canada, and UK, and the primary reason for that is one, immediate treatment, recognition that education and recognition that you are having a stroke, and access to immediate care and access to immediate treatment. Okay. Next slide, please. Now here's a kicker. So you look at these numbers, right? You look at the stroke mortality rates from 2017 to 2020, right? And you see Guyana, right? Their stroke mortality increased. Trinidad decreased significantly. Jamaica and Barbados decreased significantly. And the US has decreased significantly. Stroke mortality is decreasing worldwide. And the primary reason for that is how we treat strokes. That's the primary reason. And one of the secondary reasons is access to treatment. So if you figure out that if you feel like you're having a stroke, you should go to the hospital almost immediately once you recognize the symptoms for strokes, okay? I'll let you go back to the full screen and whenever you want, whenever you wish, from the current slide. Right? So good. And if you're from the Caribbean, I want you to digest this slide significantly. And because the key here is education, we must educate our families and our patients and our staff and it can be at any age, right? What constitutes a stroke? Remember the acronym FAST: facial weakness, arm weakness or leg weakness. It's usually arm weakness, speech impairment, difficulty speaking or drooling, and it's time to call the ambulance, FAST, FAST, right? So we can prevent these strokes. Next slide, please. And look, if you look just in Trinidad and Tobago and Guyana, just for comparison, and you look at the primary causes of death, right? In Trinidad, you look, it's heart disease, diabetes, and strokes, right? And Guyana is about the same. And you look at the rates per 100,000 and where we're ranked, you know, in look at strokes, it's almost 50 per 100,000, right? In Guyana, right, it's significantly higher, almost 149, right? And look where they're ranked in the world and where Trinidad is ranked in the world. These numbers are devastating, right? And again, it's primarily access and treatment, right? Immediate treatment, hence the high mortality rates. And I truly believe we can do better, and we are doing better. Next slide, please. So the stroke continuum, how do we manage these strokes from the moment from here, from what we're doing today, right? Public awareness, education of the population, prevention of strokes by doing these education pieces, right? The acute or hyperacute management of strokes, getting to the hospital within 4 hours, the acute management of strokes and doing what we do with different types of medication, rehabilitation, and community reintegration. Getting the patient back to work is what we try to do. And that's very difficult here in the Caribbean, getting the patient back to work, right? Next slide, please. Right? How do we manage strokes, right? Throughout the Caribbean, let me speak specifically for Trinidad and compared to the United States. If you get to the hospital, if you start having stroke symptoms, you must get to the hospital within 4.5 hours. Then we can inject this medication called TPA, which is called tissue plasminogen activator, directly into the blood vessels. So that breaks up, it's a clot busting medication that can break up the clot, which decreases mortality significantly. However, and also we can do something called endovascular mechanical thrombectomy, where we insert some forceps or a little grabber into one of the larger blood vessels. We thread it up through the blood, all the way up to the blood vessels, and we remove the clot from the brain, right? You can always look this up on YouTube, endovascular mechanical thrombectomy. Unfortunately, TPA is not offered in our public healthcare systems, right? Neither is endovascular mechanical thrombectomy. It is offered, however, in the private hospital system in Trinidad and Tobago. However, it costs, you must swipe your card for 40,000 TT dollars or sometimes higher before this medication is given to you. And there are risks of bleeding and there are risks of death, but that's the risk we are willing to take. We have a rule in, rule out criteria for treatment with TPA. However, if the patient is unable to get these medications and they present to the hospital later, the only other treatment is watch and observe, right? Watchful waiting, and the treatment with aspirin, okay? There are very few places in Trinidad and Tobago that can offer endovascular mechanical thrombectomy, or there are very few practitioners. Usually we require either a neurosurgeon or a cardiothoracic surgeon to do these procedures, right? And it must be done within 24 hours. A lot of patients wait till the next day to present to the hospital. Some people present 2 or 3 days later, which isn't good, obviously. Next slide, please. Right. So now, once you've been treated for strokes and you've been in the hospital for the average length of stay in the hospital, which is at the acute care hospital, right, is about 3 to 4 days. In the States, about 2 to 3 days, right? Once that is done, what happens? Locally in Trinidad and Tobago and across the Caribbean, the English-speaking Caribbean, most patients are discharged home. However, in the United States, about 70% of their patients get discharged to long-term acute care hospitals or outpatient rehabilitation hospitals, where you get the best potential or opportunities for increase in function and return to function, right? If you get discharged home, right, where you get very minimal rehabilitation care, right, the likelihood of you return to function, fully functional, is decreased significantly. So as of September 1st, 2023, the Trinidad and Tobago now has the first private inpatient rehabilitation facility in the English-speaking Caribbean. In the past, I would have had to send patients to Cuba for inpatient rehab. I've sent patients to Cuba, a few patients to Cuba. I've sent many patients to the United States, including Florida and Washington, D.C., right, and New York. And I've only sent one patient back to England, right? Next slide, please. What is inpatient rehab? Inpatient rehab is, once the patient has been discharged from the hospital, is where you can get physical therapy, occupational therapy, and speech and language pathology aggressively daily for a minimum of 5 days per week. Most places in the States, right, and which is governed by the United States government, they say you must do at least 6 days per week. In Trinidad, we push it to 5 days a week, primarily due to human resources, right? Next slide, please. So once you've been discharged from the hospital, be it whatever inpatient hospital the patient was in for about 2 or 3 days, they've been treated. We discharge the patient to post-acute care, which is the inpatient rehabilitation hospital, where they will get the aggressive inpatient rehab. We presently have an inpatient rehab in Trinidad at Community Hospital of the Seventh-day Adventist, which Dr. Carroll, who's the new CEO of Community Hospital, has been graciously obliged us to start this program at his institution, because he had the foresight to see that this will be a great opportunity to save lives throughout the Caribbean. So since we've started, we've had many patients. This week alone, we're expecting 3 inpatients, right? And currently we have 2 inpatients, right? So this is, yes, obviously there's a cost involved. We're not subsidized by any government, so, and we're trying to make it as accommodating as accessible as possible for the average man or woman, right? Next slide, please. Obviously, these numbers, we went over it, and we've talked about the benefits of inpatient rehab and the success rate. There have been tons of scientific documentation and data showing the benefits of inpatient rehabilitation. We just recently got a patient from New York with a TBI that was flown into Trinidad. Obviously, I can't say the patient's name. If we weren't here providing the care, that patient would not have been able to return home. So the inpatient rehabilitation facility, if anyone has to advocate for us or help us, please do, because this definitely saved lives. And these are one of the ways we can decrease the stroke mortality throughout the Caribbean, from Guyana to Barbados to Trinidad and Tobago and Jamaica, by decreasing the mortality rates, right? And inpatient rehabilitation plays a significant role here, right? Next slide, please. Right, just to quickly, just to, if I don't want to read verbatim the case, if you look at case 1, if you read case 1, this is a young woman who suffered a stroke. I sent her to Cuba, and she's a professional. She returned after 6 weeks, right, from Cuba. Now she's back to work and doing very well. The second patient is a local patient who stayed in Trinidad, did not have any inpatient rehabilitation, and did poorly, never returned to work. The third patient is a 55-year-old man at the time. This is about 5 years ago. This man is a high-level, high-functioning politician, right? He did exceptionally well, and he's no longer in politics, and he did so phenomenally well. I mean, I wish I could tell you his name, but I can't. But he truly is a poster child, poster person for inpatient rehab. I sent him to my hospital in the States, where I went to medical school where at Georgetown University School of Medicine in Washington, D.C., and their rehabilitation inpatient rehab center there. And man, he's definitely truly a poster child for inpatient rehab. Next slide, please. Right. And obviously, TPA is the key. TPA is very expensive in the States. However, I'm sure it's heavily subsidized, right? Mechanical thrombectomy is very high, expensive, even in Trinidad. And it's not, obviously, not everyone in Trinidad can afford $40,000 to swipe their credit card for $40,000 in a private hospital to get TPA, or to pay for a mechanical thrombectomy, which is almost $80,000 or more. right? And very few patients who go through the hospital once we do the criteria really get TPA. Nonetheless, you must present within about 4.5 hours to get these medications. Next slide, please. Right? So I am truly honored to have this opportunity to present this key. However, getting to the hospital, regardless if you're going to get TPA or thrombectomy or not, the key is get to the hospital as soon as possible. If you notice any of the symptoms of a stroke. Again, my book will be released very soon. I've been writing it for the last 5 years, but I'm waiting for inspiration so I can publish it and have it in everyone's hands. So nonetheless, I am done. Thank you guys for allowing me to do this. I am always honored to present on strokes. Thank you so much. And if we have any questions, I will open up the floor for questions now.
Yes, we just want to thank Dr. Gerard Antoine for tonight's presentation. We started a little late because of technical difficulties, but I thank God for working things out. It's now question and answer segment. So anyone with a question, just raise your hands. Oh, I could see your hands up already. Davilia, you could
Yes,
unmute.
good evening, everybody. I joined late, and I suppose doctor gave the well, like the symptoms of a stroke, but I think I missed out on that. I came in late.
Yes, I can review it quickly. So the primary symptoms is what the American Heart Association and American Stroke Association considers. We use the acronym FAST, F-A-S-T. Facial weakness, and it doesn't necessarily have facial weakness. It can be more than that. Some people have the drooping of the face, like this. Their face becomes slanted. In Trinidad, we call it twisting of the face. They have, with drooling, patients have drooling on one side of their mouth. They are unable to swallow their saliva, right? That's face. Arm weakness, it can be arm weakness or leg weakness or limb weakness. It can be on one side, usually on one side. F-A-S-T is speech. The inability to speak, which is aphasia, or difficulty speaking. And we know people can speak well. If your uncle is a lawyer and then suddenly he's unable to say watermelon or pineapple or drink, right? And we should quickly recognize something is wrong. So that's F, face weakness, A, arm weakness, speech impairment, and T is time to call the ambulance. Get to the hospital as quickly as possible.
Okay, thanks so much, Doc. Thanks so much.
Is there any other hands? Anyone want to ask a question? Just raise your hand and you could ask your question. Yes, Stephen Isaac, your hand is up. You could unmute yourself and ask your question.
Okay. Dr. Antoine, how are you doing?
Mr. Isaac, how you doing, man? I love those. You had the biggest avocados from Tobago, man. I killed them. And it was like the best. It's really the best.
Thank you. I was doing a presentation actually, and when I was finished, I saw you had tried to call me. But I got on a little late actually, when I was finished the presentation. But I just heard you mentioning something about the book, and I didn't quite get it. I was a little away from the device. So I don't know if you could just share that information with me.
No, the book is not live yet or real yet. The book is still 90% in my head. The cover is done. Maybe a chapter is done, but I'm waiting for what I think is the the inpatient rehabilitation facility at Community Hospital of the Seventh-day Adventist to be fully up and running. So I can print that on the book. It says, yes, because I've been speaking of this thing for about 20 years. And if you've ever come to any of my conferences, I've always said this, the inpatient rehabilitation hospital of the Caribbean will be up and running on a specific date. It's about 3 years behind, but I blame that on COVID. So nonetheless,
All right.
moving on.
Yes, I remember when we had the conference in 15 at the Marriott, at the, not Marriott, in Port of Spain, the Hyatt Regency Hotel. Right, yeah, I remember you mentioned that. But the reason I asked the question is that I wanted to be the first to get a copy of it, so.
Absolutely, you will be, you will be.
All right, so thanks for the presentation. I know I joined a little late when you were just about getting set up, but as usual, it was very enjoyable, and I suppose the folks would have benefited quite a lot from it. And I just want to thank you for accepting the invitation. And I know you did a fantastic presentation. Thank you so much. Appreciate it.
Oh, you're most welcome.
Yes, we have another hands up. Everton, you could unmute. Yes.
Yeah, good night, Doc. Thanks for the presentation. Just two quick question. I was told that if the person, to one of the acid tests is like if the person stick out their tongue, ask the person to stick out their tongue and see if they could move it side to side. If they can't do that, then that's one of the immediate tests you can do. I don't know how true that is. And for the last 2 years since the COVID, have you seen any spike in stroke? That's two questions.
Could you tell me, when you ask a question, can you please tell me where you're calling from, if you don't mind? Mr.
Oh,
Evans?
no, I don't mind. I'm calling from Jamaica at the moment.
Hey, Mr. Everton from Jamaica. All right. So, yeah, the answer is to the first question, how true is it? The question is, how true is it that if you stick your tongue out and if it's protruding to one side of the left, if you're having a stroke? That's a very good question, Mr. Everton. So the answer is yes, right? Because when you have a stroke with the facial drooping, it's not 100% true. It's not 100% right or wrong. However, when you're having a stroke with facial weakness, one side of the tongue has a line down the middle. The tongue has a line down the middle. So there's two muscles compressing each other. So when you have a stroke and one side of the face is weak, the stronger side pushes the tongue to the other side. So people have their tongues protrude to the other side. So when you have a stroke and you stick your tongue out, most times the tongue will protrude to the weaker side because the stronger side pushes the tongue on that side, right? So the tongue no longer comes midline and it comes to one side. And that's a sure sign of patient, something is going on with the patient, right? And that's another way we can distinguish from if it's a Bell's palsy. And that's one way we can tell if it's a Bell's palsy or a stroke, because most times we as physicians, sometimes we miss this patient maybe just having a Bell's palsy and we call it a stroke. Okay. Thanks, Mr. Everton. Next question. Thanks. That's a very good question, actually.
Okay, thanks. No, I was asking about the COVID since that was there any spike since that I know depression and everything go up at that rate too. So I just want to know if there was a spike. Did you notice any spike?
Actually, that's kind of, there was a spike, but we didn't see it in the hospital. The literature says there was a spike because COVID patients had strokes. However, patients, because in the Caribbean, I can only speak for Trinidad and Tobago, patients were afraid to come to the hospital when they were during COVID, right? So the hospital was almost like abandoned, right? So unless it became significant, so patients with transient ischemic attacks or minor strokes, if there's such a thing, they did not show up to the hospital for months later. So you did see a decrease in number of strokes because, and that one reason for that is patients were not coming to the hospital. But the literature said, the literature throughout internationally said there was an increase in strokes. Good
Okay,
question,
thank-
very good question.
Amen. Ivy Faye? Adamson, your hand is up.
Yes, yes.
Okay.
Good evening, everyone. Good evening, Dr. Antoine.
Yes.
Great presentation. Thank you so much.
Oh, you're most welcome.
I want to ask this question. If you have a stroke, if you do CT scan, is it possible that it would not show up on it?
I think you guys are doctors, you know, you're asking hard questions. And I think you know what the answers are already. That's a definitive question, medical question. And that's the best question. That's an awesome question. Let me tell you why. The whole purpose, as soon as the person walks into the hospital, the primary reason why we do a CT scan is to determine if there's bleeding in the brain. Remember, 75% of patients who bleed in their brain dies, right? And it determines how we treat the strokes. Because if we do an MRI, MRI is not going to pick up the bleeding immediately, not for about 24 hours, right? And one, MRIs are expensive and not as accessible in every place. But I'm sure every Caribbean island has a CT scan. And not every patient in Trinidad and Tobago gets an MRI, right? However, CT scan is easily accessible and we can do it quickly to determine if there's a bleed. If there's no bleed, we can treat the patients with aspirin. If there's no bleed, we can do TPA. However, if there is a bleed, we're definitely not treating with TPA, which is the medication that we inject within 4 hours, right? So that is the purpose of the CT scan. Now you can have a stroke and do the CT scan and it's absolutely negative. There's nothing there. But tomorrow, when we do the MRI, we will see something and then the patient may have arm weakness, facial weakness, leg weakness, impaired speech, and that CT scan is completely normal. So that is the answer to your question, Ivy. Ivy, where are you calling from, Mrs. Adamson?
Canada.
Canada. The answer to your question is yes.
Yes, thank
You can have a normal CT scan with a all-out stroke.
Okay, thank you so much.
You're welcome.
Great presentation again. God bless.
Thank you.
Yes. Esteline, you could go ahead and ask your question.
Okay, good evening to everyone. I'm listening in from in Guadeloupe.
Oh, excellent. Never been there.
Okay, my question is, somebody suffers a stroke, then this person ends up on life support and the brain is said to be dead. Is it possible that this person's body could still have movements, like you see the legs moving, and if so, I don't know if it's too long an explanation, but can you please explain? Thank you.
I've never been to Guadeloupe, Eastland. However, please invite me if you can. So let me answer your question. If you, these are ethical questions or ethics questions. For whatever reason, if the brain is injured or dead, as we say brain dead, the body can still move because especially with stroke patients have spasticity, right? Or abnormal movements or jerky movements, you can have spasticity. And there's specific tests that we can do, which is beyond the scope of this lecture, to determine if the patient is brain dead. So if you are brain dead, the body can still move from spasticity. And those are kind of reflex jerky movements. So the answer to your question, yes, you can have movement of your body even if the brain is dead.
Okay, thank you. Thank you very much.
You're welcome.
Davilia, your hand is up.
Okay, it's me again. Thanks again. I wanted to find out, Doc, at what age is one most likely to get a stroke? And I'm from Dominica. Sorry about that.
I've been to Dominica and I've given a lecture for Dominica. I've been there. It's beautiful. I went to my first cricket game in Dominica since I've been
Wow.
a long
Come
time ago.
again, come again.
I love that place. It's beautiful,
Thank
green
you.
and mountainous. So, Ms. Davila, how you pronounce it? Davila?
Davila.
Davila.
Yeah.
So the question is, right? Hello?
At what age is
At
one
what
most
age?
likely
So
to get a stroke?
so as you get older, it increases your risk of strokes. In Trinidad and Tobago, the age of a stroke is in the mid 50s to 60s, right? On average, what I see anecdotally, right? However, usually strokes occur on the average age in their 70s in developed countries, right? However, it's almost 10 years younger in Trinidad and Tobago. I can only speak for Trinidad and Tobago. And even, I would say about mid 60s in Tobago and late 60s in Trinidad, based upon my data that I see, and I've reviewed it I reviewed almost constantly.
Thank you, Doc. Thanks so much.
You're welcome. Miss Irving?
Good night.
Hi, Mrs. Irving. Miss Irving.
I'm in Florida.
Oh, excellent.
Okay. That's a question about my friend. She had a massive stroke about 2 or so years ago, and she lost her speech and mobility. I'm wondering if there's any hope for her coming back, to even walk.
How old is she?
She's maybe about 73 now.
Okay. So currently she's not walking?
No.
She's not speaking?
Bedridden. Mm-hmm. She
Could
moved
you
her
walk-
eyes like she celebrated her birthday on the 16th, I think it was. And I called and sang her happy birthday. They told me she moved her eye. I went to see her last year, and she looked at me, but I don't know if she recognized, it's like she's listening. The caretaker, the nurse, she said she recognized me based on her movement, her eye movement. So I don't know.
Let me say this. That's a great question. I'll tell you what the literature says, and I'll tell you what I believe. The literature says, after the scientific literature, after a year, whatever progress is made is usually about the max the patient will have after a year after the stroke, because the brain will have healed by then. It's like a broken arm. Regardless of what you do after 6 weeks, if the arm is broken and it's crooked, and that's how it healed, that's how it will stay. Right? In the brain, once the brain is healed after a stroke, about 6 months to a year out, if that's the maximum the patient has gotten after a year, the likelihood that you'll get any significant improvement after that year is slim to none. However, I'm a believer, and I have seen miracles, if you want to call it that, but I have seen progress with patients, because sometimes in Trinidad and Tobago, patients show up a year for rehab after their strokes, and we have helped them in the inpatient rehabilitation facility. And we just had another patient that we discharged from the inpatient rehabilitation facility, who had a stroke a year out. And this patient has been in bed for a year. And now that patient we have her walking in the parallel bars. So the answer is, and usually here's my bias, okay? So I'm putting it out there. Most of these studies that you see in developed countries are dictated by third parties with a lot of money and they don't want to pay. So I'm just putting it out there. So after a year, they don't want to pay for anything for rehab. So it's like, hey, the literature says nothing will be improved, so we're not paying for your rehab a year out. So that's my bias, not the literature.
Yeah, thank you.
You're welcome.
Empress Rachel.
Yes, good night, everyone. Good night, doctor.
Hi, ma'am. How are you?
I'm good. Thank you. Thank you so much for that elaborate presentation. It was really deep. I'm going to ask about, like, if somebody recognizes those kind of first, the phase, that is the first symptoms, is there any first aid that can be done before the person goes to the hospital? Because I hear medical missionaries saying that he can use like cayenne pepper under the tongue to improve blood circulation, or maybe bring down the blood pressure, because sometimes blood pressure is what causes stroke. And someone else said if they can try to sing, even if you think you don't have voice, but that way of trying to sing, it helps. So I don't know, you can tell me.
That's a very good question. So now we're in the Caribbean. Miss Rachel, where are you calling from?
Sorry, I'm calling from the UK, England.
So you're calling from England. Awesome. So
yes.
So the answer is here in the Caribbean, and I didn't know this. I went to high school in the States. I went to undergraduate in the States. I went to medical school in the States, and I came home after 45 years to practice medicine. And my patients keep telling me nutmeg. So I went and researched nutmeg and cayenne pepper. There are some values to these home remedies. They are called vasodilation, where it enlarges the blood vessel. So the answer is yes, there are some value to it. How much, we don't know, but so the cayenne pepper, the nutmeg, it's not all crazy talk. There is some value to it. However, what I will not recommend is giving the patient aspirin when the patient first has a stroke. Why? Because if it's a bleeding stroke, it will bleed more. And because we don't know the difference initially, right? The patient doesn't bleed through their nose, don't bleed through their ears or mouth. We don't know. So please do not give aspirin. Get the patient to the hospital as soon as possible. The challenge with putting something in the patient's mouth is, especially if the tongue is weak, the patient may choke, right? So especially a big round nutmeg, right? So that's one challenge, because if the tongue is weak, the face is weak, the patient may choke. But there is some truth to the cayenne pepper and also the nutmeg.
Yeah, the cayenne pepper is recommended to be under the tongue.
Yeah.
You can put it under the tongue.
Yes,
so that it doesn't choke.
Yes, there is some truth to that, Ms. Rachel.
Thank you.
You're welcome.
Yes, iPad, you could go ahead and ask your question.
iPad.
iPad,
Okay.
you guys know me.
Okay, I want to, what a smiling doctor. That means he know what he's saying. God give him the brain and the knowledge. What a God we serve. And all those you have said on this program this evening, it is really interesting, and it's only the grace of God keeping us and keeping you doctors healthy, that you can look after patients and they come out, in good health. Thank you so much. God bless you and continue your good work.
Oh, thank you so much. Hey, where are you calling from, ma'am?
I'm calling from Canada, sir.
Excellent.
But I'm from Jamaica. I'm from Jamaica.
Thank you so much.
Okay, thank you. God bless
you. It's an honor to serve.
God bless you. God bless you.
You're welcome.
Good night, Doc.
Good night, ma'am. How are you?
Good. Is stroke and heart attack the same or are they different?
They're very different. I'll tell you why. It's a good question, right? Because we're talking about the brain. Back in the day, we used to call the brain infarct a cerebral vascular accident. We've gotten away from that, right? A cerebral vascular accident, or CVA, versus a heart attack, which is a myocardial infarction, right? So the interruption of blood supply to the heart muscles is a heart attack. The interruption of blood supply to the brain is called a brain attack or a stroke. So in a way, it's very similar, right? Because the blood vessels to the heart muscles become disrupted, or the blood flow is disrupted or stops. And that's how we get a heart attack. And the same with a brain attack or stroke, the blood vessels become blocked to the brain, right? So in a way, it's very different, and in a way, it's very similar.
Are the symptoms the same, or it varies? The symptoms of getting a heart attack and the symptoms of getting a stroke.
It's very different, ma'am. Since we've talked about strokes, the symptoms for a heart attack. Now, if you have diabetes, this is not for diabetic patients, okay? Because diabetic patients, especially if your diabetes is out of control, right? This is not for diabetics. So the symptoms of heart attack is sometimes people don't even complain of pain. They complain of pressure on their chest, like a tightness in their chest. That may radiate to the left shoulder or the face or the jaw, right? Or even down the armpit, right? On the left side, right? They may even get earaches, but it's pressure versus, right? Versus pain, right? Or you can have pain, but it's usually, most patients describe it as a pressure, right? You usually have nausea, which is feeling like you're gonna vomit, right? Or a nausea, or start sweating, right? So and your heart rate increases significantly, right? So that's the usual symptoms of a heart attack versus the facial weakness, the arm weakness, the speech impairment, right? For a stroke, okay? Did that answer your question?
Yes, Doc. Thank you very much.
You're welcome.
Nora Wright, you could ask your question, Nora Wright.
Okay, thank you. Thank you so much. Very good presentation, Doc.
Thank you.
Okay, welcome. My father had an ischemic stroke in December 2020.
Yes.
He had limited, when he came out of he spent about a week in the hospital. When he came out, he was not able to walk, but then he recovered and he had limited mobility. A nurse cares for him on a weekly basis, and he's improving a lot now. He's taking his medication. Well, sometimes he doesn't take his medication as often as he should. She goes like 3 days in the week, but the days that she doesn't go, sometimes he doesn't take his medication. He's diabetic, but I noticed that his feet, because he can't work the field anymore, so he sits down at home most days. The feet are very swollen. So my question is, what kind of treatment would you recommend for, to care for his feet? Do you recommend soaking in Epsom salt water, warm salt water, or massages? He got the stroke on the right side of the brain, so it affects the left side of the body. So his left hand is a little bit, the fingers are not stretched out quite properly. So I had taken him to get physiotherapy at one point, but the blood pressure was too high, so he could not get the physiotherapy, and he has not had any physiotherapy since, because he's up in the country area and I'm in Kingston, so it's a little bit difficult to, transporting him. So as I said before, my question is, what kind of treatment will you recommend, home treatment for swollen feet at the moment?
So that's a very good observation. So patients who have, because the limb or the limbs are getting very little movement, right? The muscles, the veins, the muscles are responsible for squeezing the veins and pushing the blood back up to the heart. And if the limb is moving and the muscles aren't compressing the veins, a lot of the blood pools in the legs, right? Because of the lack of muscle movement in the legs. So that's why you see the limbs, especially the limb that has had the stroke or the arm that has had the stroke, becomes swollen and painful, but we have to make sure it's not a blood clot in the leg. If the calves are not very painful, or it's just hanging, or the swelling is just by the ankles and the feet, right? So we always have to pay attention to that. How can we treat it? The Epsom salts may help, but it'll only help. You can't have him soak his entire leg from his knee downward. But if you can get something called a compression socks, what we call TED hoses in the States, but TED hose is just the name brand, but the actual name is compression stocking. So, and there are different elasticities to these. However, in the Caribbean, it's very hot, right? And most patients don't want to keep him on all day. But if he's going to go outside and sit up for a little while, put the compression stocking on his feet, and then when he gets back into bed, or you can take it off and keep his feet elevated, or put it on like a little stool and have it raised just about above the about the same level as his leg. So the feet is not lower than his knee, right? Okay. Does that make sense?
Yes, yes, very much so. Yes, my brother actually took a little assack for him to elevate the feet, but sometimes I go there and he's not using it, so I have to keep reminding him to do so. Thank you so much.
Oh, you're welcome. You're most welcome.
Yes, and we have one more hands up. iPad, you could unmute and ask a question.
Hello. Hello.
Hi.
Yeah, I'm calling from Houston, Texas. I was wondering if you've heard of amaurosis fugax, which is a temporary loss of vision in one or both eyes, as being also a symptom of stroke, because this happened to me about a year ago, where I lost the vision in my left eye for about 6 minutes. And it came back, no other symptoms were present, none whatsoever. But when I saw my doctor the next day, he confirmed that I had the stroke, and it was confirmed by MRI. And then I was told after that, that this is one of the new symptoms that have been added.
That's very, remember when I did the presentation, I talked about the loss of vision in one eye or loss of vision in two eyes. So amaurosis fugax is like a blind coming down in either one eye or both eyes. It's like when you lower the blinds, so it comes down gradually, right? And you lose vision or it goes back up. And it's not really a new symptom per se, but that's, they was teaching that in med school when I graduated in 1998. So, and I'm sure it's been there for a while. However, it's very important, if you experience this, someone in your family has any loss of vision in either eye, one eye or both eyes, that you assume it's a stroke, especially if they're diabetic, especially if you're diabetic. And I could show what your name is. How long did you take before you went to the hospital, may I ask?
I did not go until the very next day when I had an appointment with my neurologist, because it came back and fired within 6 minutes and there was no other symptoms. So I did not recognize it as a stroke because I had not heard that before. Yeah. I've heard all about the facial drooping and the tongue and the this and the that, the arms and everything. And it seems that a lot of people are not aware that this is also a symptom.
Yes, absolutely. So we talked about the loss of vision. Some people even have like massive face pain, but usually, or eye pain, but usually pain is not associated with strokes. So you always have to take that into consideration. However, pain is more associated with Bell's palsy.
So why is this not like how they have the FACE? Why is this not being talked about so that people are aware that this is also one of the symptoms that they should be looking for? Because, you know, you're hearing face drooping, which is different from losing vision in one eye for, you know, a few minutes.
So what we put out there is things that are most common for the average person. So the average person living in rural Trinidad and Tobago can, you know, what will happen most times versus what may happen 1% of the times. You know, like 90% of patients will have this symptom. However, 1% of the time, the person would have amaurosis fugax. So, but we still teach to the med student and the doctors, we do teach them that. So I would know that, the average medical student would know that, the average therapist would know what amaurosis fugax is. So, but not, so we don't teach that to, you know, the population per se, because it's usually unlikely that that would happen, but it happens. It happens.
Interesting. Okay.
That was our last question for this evening. And again, we just want to say a big thank you to Dr. Gerard M. Antoine for tonight's presentation. And it was indeed a blessing. So right now we're just going to close off, and bow with me as I close in prayer. Eternal God and Father, we just want to give you praise. We want to give you thanks. We want to give you all the glory. Thank you, Lord, for this evening's presentation. And I just want to pray and ask that all this information that was given, oh Father, that you would help us to use it, oh Father, not only to help ourselves, but to share it with those who are in need, that they may be aware also. We want to give you praise. Bless everyone that is represented there, oh Father. And I ask your special blessing, oh Father, on Dr. Gerard, as he continues to speak, oh Father. May your will be done, oh Father. Thank you for this evening. And, oh Lord, as we go to our beds, may your angels keep us. We give you praise, we give you thanks in Jesus' name. Amen. So thank you again, and thank you everyone for joining us this evening. I hope and pray that all the information that we received, that we will use it wisely. So now you could say your goodbyes and your hellos as we depart.
Thanks, everyone.
Thank you, everyone. Thank you, doctor, for your valuable information. God bless you.
Amen. Amen.
Thank you, doctor. Thank you, doctor. Thank you, Brother Shad and Sister Angela. Thank you so much. Thank you, thank you, thank you. As I said, you always bring on the best. God bless and thank you. Good night, everyone.
Okay, good night. Good night, everyone.
Good night. Good night.
Good night, everyone.
Good night. And
Shalom, shalom, shalom.